there is the need to manage. So what are the management strategies? Obviously, we need to control cases and carriers. If you are talking about cases, then we mean individuals who have the infection and are showing the signs and symptoms on the condition. You may have other individuals who also have the infectious agent but are not showing signs and symptoms. These individuals are described as carriers. So, in order to prevent the spread of the condition, it is also necessary to control carriers. Remember, we said the only animal forms in which these organisms survive is human. So, human are described as the only reservoir for typhoid fever. For that matter, we need to control carriers to cut off further supply of the infections. So we control cases and carriers. This condition is defined as an index of sanitation, and therefore, to avoid the spread of the condition, it's also very necessary to control sanitation, including hygiene, water sources, everything we need to control. Then finally, immunization, so that we develop antibodies way before we are exposed to the infection, for the antibodies to deal with the infectious agent for us. So let's see the approach. So when it comes to cases, those who have the infections plus signs and symptoms, prompt diagnosis is very, very important. Remember, it's an infection. If you fail to diagnose and manage it in the early cases, it will only progress and create a lot of problems. So it is important that you diagnose as early as possible. And of course, since this is infectious, it is contagious, then you need to notify the case, that is the one who is suffering, the index case, and possibly you isolate the person from healthy individuals. Else, he or she will easily spread the condition to others. Then, of course, we are dealing with an infectious agent, so the appropriate chemotherapeutic agent must be used to clear the organisms. Obviously, it's a bacterial infection, and therefore we are looking at antibiotics. Other control measures of cases is to disinfect the person's stool and urine. These are some of the sources through which the organism spreads. So you disinfect. So you can use, for example, 5% Cresol or 2% chlorine. You remember chlorine and COVID-19. It was very popular. They were spraying everywhere with chlorine. Then, of course, to make sure that you have indeed cleared the organisms and cleared forever, you have to do a follow-up stool and urine examination about 3 to 4 months after you have managed the case. And if possible, you do a final confirmatory test 12 months after discharge. So let's see how this is done. What are then our goals of management? Obviously, we would need to manage the infection. So we clear the infectious agent. That will help us to reduce, obviously, morbidity and mortality. These may occur as a result of complications that comes with enteric fever. How do you manage and clear the organisms? Unfortunately, over the years, we've been having the emergence of resistant strains of Salmonella typhi. Previously, these common and very simple antibiotics were effective. Ampicillin, chloramphenicol, and our own cotrimazole were all effective. But around the 1980s, because of misuse of these agents, we develop, or the organisms develop, resistance to these very, very common, very cheap antibiotics. And these are referred to as the multi-drug resistant strains. So if you have the typhoid bacterial that is resistant to either ampicillin, chloramphenicol, and septrin, then we say that they are multi-drug resistant strains. Nowadays, we even have extended multi-drug resistant strains that are not only resistant to the multi-drugs that we've discussed, but including fluoroquinolones and even some of the third generation cephalosporins. Drug resistance is a very serious issue. Notwithstanding, currently our first line treatment options include fluoroquinolones, provided the isolate is susceptible to it. So once you test and culture and sensitivity results are saying that the organism is susceptible or sensitive to fluoroquinolones, then obviously these agents should be fluoxetine and the likes. Very, very effective. Then second line agents will be the third generation cephalosporins. Remember the oral forms and the injectable forms. Should in case you have resistance to fluoroquinolones, then our chances will be the macrolide, azithromycin, carbapenems, and tetracycline. These will be the options should in case you are having fluoroquinolone resistance. Now, what is it with fluoroquinolones? When you are using fluoroquinolones, your minimum duration of treatment should be 10 days minimum for typhoid infections. But preferably, it is advised that you extend it to 14 days to make sure that you have cleared everything. Note that the first generation fluoroquinolone, nalidixic acid, is not effective against typhoid. The second generation agents are effective. Examples: ciprofloxacin, norfloxacin, and even the current ones, levofloxacin, that is very common. Depending on the brand, the price is manageable. What are the benefits if you are on fluoroquinolones in relation to the management of typhoid fever with its signs and symptoms and complications, as well as the possibility of leaving some of the bacteria in the stool to continue the spread? If you are using fluoroquinolones, then what are the possible benefits? In terms of cure rate, you have as high as more than 96% cure rate if you are using fluoroquinolones. Relapse, which is a negative issue, we don't want a relapse in the management of typhoid fever. So we would want a very low relapse. All things being equal, we even want to get zero relapse rate. But with fluoroquinolones, you are likely going to have less than 2% relapse rate. Fecal carriage that will continue the spread is also very effective, less than 2%. When you are on it, at what time do you hope that the fever that comes with the condition will go? It won't go more than 4 days. Less than 4 days, you realize that the fever is going down. These are some of the benefits that one will enjoy if you are put on fluoroquinolones. Remember the normal counseling points on fluoroquinolones, especially when you are doing oral medications. Its interaction in the GIT with heavy metals, calcium, aluminum, and the likes. But that doesn't mean that you make it very strict, that don't take milk, don't take this. It's all about spacing. So make sure you space them. You take the fluoroquinolones maybe 2 hours before you take your heavy metal containing food or medication, iron supplement. Do not make it straight away that you should not. This interaction is within the GIT, and therefore, if you are able to space the two and give adequate time, the fluoroquinolones will be well absorbed. Then you can take metal containing food or drug. How about macrolide benefits in terms of same parameters? So macrolides enjoy a very high cure rate, 81 to 100%. Relapse rate is non-existent, 0% relapse rate. Very, very effective agent. Fecal carriage is also very small, up to 1.6%, but it will take a relatively longer time compared to fluoroquinolones for fever clearance. While fluoroquinolones will not take more than 4 days, macrolides are going to take about 4 to 6 days for fecal clearance or fever clearance. Third generation cephalosporins, cure rate 90 to 95%. Relapse in general is 3 to 6%, but if you are using cefoperazone, then you are getting 0% relapse rate. Fecal carriage is 3%, but fever clearance is not encouraging. It may have to take up to 7 days before the fever is cleared. These are the doses for the various cephalosporins that you can use: cefixime, ceftriaxone, cefotaxime, and cefoperazone, the one that you are getting 0% relapse rate. Any question? Class captain.
No question, please.
All right. All right. So should in case your isolate is the extended multi-drug release type, then you are doing a combination of the macrolide, azithromycin, plus or minus any of the carbapenems. Remember, it will depend on the severity though, but that is the general rule, including fecal carriage. Make sure you hit 14 days. But if you do between 10 to 14 days, fine, it is okay. For those who are carriers, to be able to clear the fecal carriage and halt the spread of the infection, you use fluoroquinolones, including ciprofloxacin or norfloxacin. Rate is very low, 35 to 40% bioavailability, which means most of the drugs will be left within the GIT. And of course, you want the GIT to clear the fecal carriage for you. So norfloxacin for about 2 to 6 weeks, and this may be very effective in clearing fecal carriage. In severe conditions, because this could spark an inflammatory response. Remember when we're looking at the normal course of the condition, week 1, week 2, week 3, a whole lot of problems. So steroids may be used to attenuate the severe inflammatory response. But remember that steroids could also minimize the person's immunity. So with this argument, we only reserve the use of steroids for severe conditions. We don't want to create complications. So unless the individual is severely ill, which correlates with severe inflammation, you hold your corticosteroids, do not use. So typically, dexamethasone at this dose, 3 milligram per kilogram body weight start, then 1 milligram per kilogram body weight, 6 hourly for 8 doses could be used with the antibiotic as part of the supportive care. This is known to reduce mortality in those who are severely ill. But due to the controversy of increased relapse due to reduced immunity, just reserve this only for those who are severely ill and their life is being threatened. How about non-pharmacological management? How do you approach it? We've been saying that is an index of hygiene, index of sanitation, and therefore having a good source of drinking water will help us a lot. Personal hygiene. You visit the washroom, you wash your hands. Remember, you can spread it through feces and urine. So make sure that you keep tight when it comes to personal hygiene. Once you defecate and you're a carrier, you are always going to spread the condition. So open defecation, this will be washed into river bodies, and those at the end are going to drink this water and then get the problems. So provision of appropriate sanitary areas, appropriate latrines and those things will help to control the condition. Food vendors, critical, because they are supplying or feeding a whole lot of people. So the moment the person has it, for example, the person visits the washroom, fails to wash the hands very well, and then comes back and serve, and unfortunately contaminates the food, can imagine the number of individuals that this person is going to spread the condition to. And therefore, food vendors are advised to observe personal hygiene and, if possible, even take medications as a form of vaccine to prevent this condition in food vendors. Now, and therefore, in terms of immunization, to try and develop antibodies against them, what are the options and who are the targets? Individuals who live in areas where you have high levels of typhoid fever, so residents of endemic areas. If somebody gets where the person lives, by all means, he will get household contact, friends. All these individuals qualify to be vaccinated. And of course, your mates, your friends also becomes high target. And therefore, these individuals also would have to demand or get the vaccination and hopefully attains available. We have the injectable one and the oral one. So the injectable typhoid vaccine is called the Tafin VI or Tafivax, and the oral one is Attakorah. How do we take these two, the oral and the injectable ones? So when you get the oral one, how are you going to give it? You swallow one capsule. It's in the form of capsules, but you take a total of 4 doses every other day so that you complete maximum within a week, you complete. If you are not at 6 years and above, you don't qualify to take this oral typhoid vaccine. Remember to take a booster dose 5 years after the very last one. The injectable one is just 1 dose. So it is injected once. And then before you travel, if you are coming from an areas where we don't have, you have to take it way back 2 weeks before you come. If you are not 2 years, you can't take this one. Booster doses are taken 2 years after first dose. Class captain and the group, any question on typhoid? If not, that will be the end. A very short topic to another infectious condition.
Hello, sir. Please, could you go over the wideout test? Thank you.
Okay, so with that test is one of those serological tests that we use to identify. Unfortunately, there are issues with the without test, its sensitivity, advantage of the antigens that we have on the organism. Remember, we said the organism has the O antigen and the H antigen that is found on the flagella. The H is very strong, highly immunogenic, very, very sensitive. And therefore, if you are going to use it as the test, since it's at a very diluted concentration as compared to the O antigen. The O antigen is not that sensitive. So we have titers, dilutions that when you pick, for example, the blood sample from the individual, you need to do serial dilutions as you do or you did back in school. Even in microbiology, you did a lot of serial dilutions. So if you pick the sample, it is concentrated. And that one, if you get the antigen antibody reaction after adding the reagent, then that may not show that you have enough. But once you dilute it to a certain extent, and still, once you add the reagent, you are getting reactions, then it means that if you are to extrapolate it to the concentrate, then you have heavy loads. And for that matter, depending on the lab, always the H antigen is taken as a significant diagnostic test. When at a higher dilution compared to the O antigen, you have antibody-antigen reaction. So you can see, for example, these two. The O antigen is considered significant at a dilution of 1 in 100, whilst the H antigen is considered significant when you have a reaction in a diluted sample that is 1 in 200. Other references may take, for example, even a higher dilutions. The sample, let's say blood sample from the individual, if the organism is there, then of course you are going to get the antigens within the blood samples. So you prepare your sample or your reagent with antibodies against this typhoid bacteria. So the sample having the organism. So you mix the two and then you create special dilutions. So this is an example. So the original sample has been diluted 20 times in this tube, 40 times, 80 times, 160 times, 320 times, 640 times. Pour your reagent in all of them. So for example, in this test, they are having the dilution in 1/160, and it has shown agglutination. You see these two, the last two are clear. So it means in those two, no reaction occurred between the antigen and then the antibody. That is the sample and the reagent. But the highest dilution was 1/160. That is when the reaction occurred. So if per the reference of that lab, it is true that for the O antigen, they are getting, if you get, then if you are using the H antigen test, and then you realize that you get, for example, the reaction in 1/330 upwards, then it shows that the test is significant. But remember that we said there are issues with the test in terms of sensitivity. We cited possible reasons as to why somebody can present with false positive or false negative results. So it's all about the person having the infection who have the bacteria in his or her body will develop antibodies. You pick the samples, you add the reagent that is flagellar H or the somatic O, then you add it to diluted solutions of the sample. And according to the reference of the lab, depending on which diluted solution that they deem. Okay, so as we said, we have to switch to another infectious topic and then we see what we can do. So let's switch to meningitis, also a pretty short topic. All right, what says the time? It's now getting to 10. We hope that we can finish it today. So meningitis, we are actually talking about the infectious one, not the one that you get it aseptic meningitis. But in meningitis, you can get it without an infection. So the person will be having meningeal inflammation, but you check for culture and sensitivity and there is no isolate. That is what we mean by aseptic meningitis. But our focus will be mainly on the one that you get some isolate, be it a parasite, bacteria, fungi, or virus. Okay, so as introductions, we look at your brain and your spinal cord, they are always surrounded by certain membranes. These are normally three. If you are moving from outside, let's say from the skull towards the brain, so the layer that is outmost, the outmost layer is called the dura mater. The next one is the arachnoid mater, and the pia mater that in most cases is even attached to the brain or the spinal cord is called the pia mater. In between the arachnoid, that is the second, and the pia mater is a certain space that holds the cerebrospinal fluid, and this space is called the subarachnoid space. Subarachnoid space. If you get an infection, and of course it leads to then you are getting meningitis of the leptomeninges, because the two, the arachnoid and the pia mater, that is the arachnoid mater, is the subarachnoid space. You have a set the subarachnoid space. Remember, these three membranes does not only cover your brain, but also